work in. Thanks, Martin. So we have around 97 validated CSOs that are spread across the African continent that we actively engage in on different projects that we work on. So some of the members that we work with in Southern African countries such as Angola, Zambia, Namibia, Zimbabwe, Botswana. And currently, as of this month, we have 37 validated members in Southern Africa. And we have about another, a new member from Southern Africa that will be joining this month. Then from East Africa, we have around 23 validated members, with most of our members concentrated in countries such as Kenya, such as Tanzania. And you see that most of the members that we work with in East Africa, they work in sex work, in public health. So it's actually intentional as PVA Africa. We try to work with organizations that are traditionally disadvantaged, such as sex workers, such as the LGBTQ community. So it's actually intentional when we try to bring more members that actually work in these sectors. Then almost the strategy of 2023 has been to try to increase our membership in countries such as Somalia, such as South Sudan, as most of these countries, we don't have a lot of active members from these countries. And I think it could be probably because of the social unrest that is present in these countries. And then in North Africa, we have 3 active members in North Africa. And one of the members I think is present here is Yoba. So I think we'll be trying to engage Yoba probably from this month going forward to try to increase the membership of PVA Africa in this region. Then in Central Africa, we have 17 validated members, with most of our members focusing on public health and research. And you see that in Central Africa, the country that is most represented is Cameroon, which is followed by DRC. So we actually don't have a lot of members in Portuguese-speaking countries, such as Equatorial Guinea or Cape Verde. So we're still trying to find more members in this region. Then in West Africa, we have 17 validated members. And again, most of our members, they focus on research and sex work. And most of our members, they're focused in countries such as Nigeria and Ghana. So I think the main reason is that these are English-speaking countries. So we're also trying to spread our wings to Francophone speaking countries such as Cote d'Ivoire. Then you see that most of our members, they don't work in one sector. They work in different sectors, such as community mobilization, public health, etc. So this is to ensure, like I said before, to ensure that those sectors that are traditionally discriminated against, they're actually saved. So these sectors include people such as sex work, people that are affected by drugs, and the LGBTQ community. But you also see that the most represented sector in the PVA Africa membership is actually community mobilization. I think where most of the people that are on this call work in. Then the least represented sector is actually sex work, which is only accounting for 3% of all the members. So we also, PVA Africa is intentionally trying to increase the representation of these sectors such as sex work, so that the health rights of these these sectors are actually meaningfully represented. So this is the outline and the representation of PVA Africa membership across the African continent. So before we move on to the main event of today, before I pass on the baton to George, so I'll just be showing you a very brief video on mental health that was published by BBC. So just give me a few seconds. Amat, can you confirm if you can see this video?
Yes, we can see the page, but it hasn't started yet. Yeah.
Okay, fine, fantastic. Let me start.
The disruption and uncertainty caused by COVID-19 over the past 15 months has left workers suffering stress and exhaustion.
We've been calling it the silent pandemic. mental health is at the top of the agenda for pretty much every organization.
The WHO, the World Health Organization, estimated mental health problems cost $1 trillion per year in lost productivity. With people opting to still want to continue in some form working from home, how do you create that separation?
We just have to set boundaries. We just have to decide when we are going to stop and what needs at home we are going to take care of.
And Tim, I understand you've had your own mental health experiences. I'm just wondering, how much does that inform you on how you, how you do your job today?
I've been treated for post-traumatic stress following incident early in my life in which I almost died. I realise how much personal stigma actually happens. The first contact really matters. So yes, creating a place where it's easy to talk.
Supporting mental health is really an individual thing. You can provide, I think, services at scale, but really understanding what are the drivers and the root cause is what's most important. Well, tell me more, right? That's my favorite line. Tell me more. It's not judgmental. Even sometimes asking the word why. Why did you do that? Why did that happen? Has an element of judgment to it.
We have a moment in which if we can really equip line managers to ask the right questions, to have an open conversation, I think we can really make a change. We can destigmatize mental health for a generation.
Thank you so much for that, Takuzwa. I don't know if you have anything else to say before I proceed.
Thanks, Matt. Thanks, Matt. That's what I wanted to share. So you can keep in mind some of the terms that were shared in this video, as you probably have it.
Okay. Thanks a lot, Takuzwa, for providing some context to our important discussion today. So October is Mental Health Awareness Month, and October shares this month with Breast Cancer Month, but Breast Cancer Awareness Month as well. But the reason why we chose mental health awareness is because as we are closing off some of the projects for PVA Africa, because we were doing some subgranting projects in Liberia, we had one in Malawi, we had one in Uganda, we had one in Kenya, Tanzania, and we had one spanning Egypt, Morocco, and Tunisia. So those projects are coming to an end at the end of this month. And we had to go to Uganda to interact with some nurses and midwives just to get some of their stories during the COVID-19 pandemic over the past 3 years, what their experience has been. And we'll be releasing some of these stories in November, just so that you can also share in the experience that we had. It involved going into so many rural areas in Uganda where the nurses and midwives are working with communities. And as we were going around with the videographer, we were getting such interesting stories and perspectives from the nurses about their experiences during COVID. There was a male nurse in Uganda who ended up because he works in one of the islands called Kalangala in Lake Victoria. So it's actually 6-hour boat ride from Entebbe, from the mainland into the island where he works on. And he was telling us of this instance where there was a mother on the island that he was working on, who he had to take to a clinic on a different island, which was going to be about a 3-hour boat ride. And he had to be the coxswain who was steering the boat while also helping the mother to give birth. And as he was saying this story, sometimes you just wonder, what kind of toll does this take on the mental health of healthcare workers? As part of that journey, there was also a nurse who was working with some child soldiers. One of the child soldiers lost their arm when there was a bomb that detonated close to them as they were fighting with the Ugandan military. And a 17-year-old child whose arm was basically torn off, and the rest of his comrades had died during the bombing. So, when the nurse has to treat these kinds of cases and listen to these kinds of stories, you just have to wonder what kind of, trauma they go through, and also in terms of COVID, So we were just curious about, how does mental health affect healthcare workers, and also you who work so directly with them, especially during the pandemic. That's why it was so important to call George to come and address this important conversation. And we're hoping that you'll also be able to chip in with your own experiences and questions and concerns towards the end of the meeting, so that we can have a more fruitful and wholesome discussion that gives more perspective to this really important issue. So without any further ado, George, you're welcome to take the stage. Yeah, go ahead, introduce yourself, and then you can proceed with your presentation. Thank you very much. Hey, George, we can't hear you. George, maybe you could try with the laptop. And
can you hear me now?
Yes. You can use the phone for the visual and the laptop for the audio. That should be fine.
Okay.
Thanks.
Thank you very much. So let me. Okay, Takwa, are you going to share the presentation?
Definitely, I can share for you if it's fine.
Okay.
Great.
Just give me a few seconds before I show it.
Okay.
Hey, can you confirm if you can see my screen?
Yes, we can.
Yeah, thanks.
Okay, thank you very much. Let me, first of all, appreciate this opportunity that we can come to make this presentation. As guided by the meeting, the theme or the title is mental health and psychosocial support, addressing individuals and communities' mental health challenges during pandemics. So, firstly, we may need to understand the meaning of a pandemic. A pandemic is a health outbreak that affects many countries. If the outbreak is within in this case, about many reasons we can give for a pandemic is COVID-19. So my presentation has been skewed towards pandemics. Go with the introduction. Can we go to?
Yeah, you can go to the next slide.
Can you go to the? Okay, thank you. Mental health has been one of crucial areas that require actions during pandemics. Although it is least appreciated or acknowledged, and I would want to share that Malawi has gone through critical times of COVID-19 and cholera that affected both those who suffered the disease, and mental health also extends to relations of such people, not only the victims, the direct victims. The presentation will attempt to show linkages of mental health with the pandemics, as well as the proposed remediation. As this is being done, we'll be sharing experiences of Malawi to the same. We can go to the next slide. Firstly, we would want to look at the importance of mental health and the psychosocial support during pandemics. Why is it important? It is important because it has shown that the majority of people admitted in hospitals, and even those who die or who died, like in Malawi, those who were admitted during the COVID-19 peak time, those who died, including in cholera, have been men and the youth. Why men? Men are not used to sleeping in hospitals, unlike women who during childbirth, they sleep in a hospital, and also they are always guardians when someone is sick in the hospital or admitted. So women are used to hospital life, and because of that, most men died because of fear. Once admitted in a hospital, they would be afraid, and the others would not even want to know whether they had COVID-19. The same with the cholera. The youth also died. The youth, it is because of considering their age. One would think, I am young, I should not die young, and that brings fear. So the fact that we had the men dying more than women, it must call for something, which is strange. It means that it's not just a health issue. It goes beyond that. That is where mental health comes in. And also, it is important to discuss mental health and psychosocial support during pandemics because of people who get affected after someone has died. We have widows. Of course, we can also have widowers there. We can have stroke widowers, men losing their wives, women losing their husbands. Those people get affected. Sometimes at a funeral, once a burial has taken place, people disengage, they go to their homes, they forget what is still going on in the minds of such people. To the extent that, yes, we have talked about widows and orphans being created who suffer, but some of them even die at the end. For example, we are looking at connected actions from the pandemics linked to mental health, where others have committed suicide. We have had people who have committed suicide. Someone has lost everything, has lost all suicide, migration, people are going to other places, which affects their economic status. And here we are talking about the experiences that have happened here in Malawi. And then conditions that result from such instance. There's depression. So depression is goes to even mental disorders. When sick or the breadwinner has gone, there's poverty that comes in. That poverty goes into the mind as well. Because of challenges that happened, sometimes it has led to some behaviors for the youth going into drug abuse, others going into prostitution because the person they depended upon has been lost. But people just look at the pandemic without seeing the associated elements that continue to affect survivors or the people related who have been left. So we can go to the next slide. Next slide.
Yeah, because of network is taking time.
Okay, it is taking time, yes. Having seen the importance of discussing mental health and the relevance of psychosocial support, we look at the strategies that we think okay, the strategy for integrating mental health and psychosocial support into the pandemic response. In stakeholders, including civil society organizations like ourselves, to respond to COVID-19, including cholera. But one thing we noted with COVID-19 was that no budget for mental health and the psychosocial support interventions. Of course, Malawi was taken by surprise, both during COVID-19 and the cholera, because with COVID-19, we used to hear about it in China and coming to Africa, coming to neighboring countries like South Africa. But when it came to Malawi, we were at least prepared. We did not have treatment centers. We had to start late screening at our borders and airports. However, when all the funding came, it was one of the richest disease area because of funding. There was nothing much talked about mental health. And our recommendation as the Malawi Health Equity Network, where I work as the executive director, is that there should always be a budget in the government budget for mental health. Knowing what we have said earlier on, that when one is sick, they get affected. For men, they will die, most of them. If almost 50% of the men who get 50% of the men who get admitted. Sometimes people talk about 75% will die because of mental health and fear. And also, we need to have more experts that are conversant with the issues of mental health to provide social support at different levels, at national level, district level, community level, so that these people can move in, especially when, in fact, a family has been affected or when one is unwell. And we think that the private sector needs to also be encouraged to take on psychosocial support, counseling and guidance as a business, where they can open many centers. I think either we might have jumped a slide here, or the slide will come, where I have shown some of the challenges that are there. For example, where we have limited numbers of places where people can get social support, and also where it is at least talked about or it is not funded, and people are not aware of the importance of mental health. So it is not like a challenge at all. And in that slide, if it is to come, if we have not missed it, we have not jumped it, I also talked about the lack of points or sites in our public places, like public hospitals and the like, where someone can go and seek psychosocial support. So when the private sector can come in, you can choose to go to a government place or to the private sector. We also look at investing in infrastructure and systems, because when we talk about cholera, for example, in Malawi, it also coincided with the Cyclone Freddy, where communication, like movement of motor vehicles, became a challenge. Roads were impassable. There should be a system in which there could be someone can call when they are affected and get the support they need. There's need to have programs on our radio stations. Yes, it is broadcasting, but somewhere, somehow, you may reach someone who is affected and the programs can help them. This is being taken as an important area during the pandemics. And also to have, I have used the term fixed public address systems. Like you could have in the cities some big speakers. We have seen such speakers being used in religious circles, especially at our mosques, that warn people about the time to pray. If we can have similar systems, you can even have some talks, some counseling to the people. Even someone who doesn't have a radio receiver to get this. This is number 3. So we can check if there's number 2, because I have not opened my laptop. We check or we go to the next one.
Okay, sure. Can you see the number 3 there?
Yes.
The number 2, so the number 2.
I don't know the others.
Not yet. I think it's a slide before number 3.
Yes.
Yeah,
Yes, this is number 2. Yes. So we missed number 2. Number 3 was responding to number 3 was responding to number 2 as a solution. So number 2 is looking at the challenges individuals and communities face in accessing mental health services. So these experiences from Malawi as well, because we noted that the majority of Malawians, and here we're talking about citizens, if it applies to other countries as well, do not appreciate mental health and the psychosocial support. There's no awareness raising. This does not only go with the less educated, even the educated. We have seen some of them are dying. I remember during COVID-19, we had someone who was who had been admitted in a treatment center. When he came out, he testified that most of the friends he saw die. It was because of fear, especially men. So this, whenever someone is distressed, they must seek some support. They should not stand on their own, because the more someone die. When I talked about the private sector to come in, it is because we have a few experts. It is a rare profession in Malawi to have someone. Yes, we know, like in the university, we have psychology as a course, and some psychologists have tried to come in, like during Cyclone Freddy, to come in, but most of them do not link this with the counseling, psychosocial support. Therefore, we have less of them. In which case, it should be promoted as a profession in our schools, not just psychology. Psychology is about the development of the mind and other concepts. But here we are talking about how can you sit down with somebody so that they understand. You move with them and remove them from their cocoon and give them some hope where they think they are dying. They should know that they can live. So this is a rare profession. I have given examples of people who died of COVID-19, but let me give an example of my own relation, my own brother, who was admitted for hypertension. He has hypertension, and after sleeping in the hospital, he was better. After 3 days, one day he just changed. He said, "I'm dying. I think I'm dying." We tried to talk to him, but he started, saying bye to us. And until one night, I just decided to go and be a guardian and sleep there. So in our public hospitals, guardians sleep on the floor. That is 2 months ago. I slept on the floor. My elder brother said, "No, you can't sleep there." I said, "No, I will." That night, he was quiet, but I understand the past 4 nights, he kept on crying and mentioning the dead, dead grandparents. He was quiet. In the morning, he was calm, and he was discharged the following day, just because I shared time with him there. Had that not happened, I definitely would have lost him. Even now, he tells me that I would have died. This is what has been happening with the COVID-19. Someone is confined in a tent. No visitors are allowed to go there. No relations are allowed to go there. There's a gate. If you are bringing food, you must stand at the gate and the food is taken into the tent. How can you expect someone to survive just because there's oxygen, there's a ventilator? It's not about that. That person is also thinking day and night. And it should be appreciated that in our hospitals, most times people die at night. They die at night because there's quietness. They have a lot of time to think. There are no disturbances. Hence, we need more experts who should come in during the time of pandemics. And here, much as we are talking about pandemics, we can talk about even disasters. Like the cyclone Fred I just mentioned. I know Zimbabwe was also affected by, was it Gome, another cyclone. So it should be a profession we should be promoting as the healthy advocates. And I talked about phones, radio system. It was trying to address the problem number 3, where we have no systems, no infrastructure in our public places for psychosocial support. How someone can be reached, there's no such. I talked about toll-free numbers, where someone can call, even if they don't have airtime, but the government must pay for that, or a certain system must pay for that. And someone can even air out their views, especially with men. As we earlier said, that most men die because they harbor fears, they don't share fears. And probably if they are not on a face-to-face interaction with somebody, with such systems, it can help them to speak. In here, let me share an example of my son. He was at one of the colleges. He had just graduated. And one evening, he came to me and said, "Dad, I have a friend. We used to be together at college. She says her father is suffering from COVID. He's refusing to go to the hospital. He has lost hope." Here we are talking about someone managing education in a region like a division. The education sector, we are at the national level where we have the principal secretary for education, and the 5 or 4 districts are grouped under what is called a division, education division. He's the manager for an education division before you go down to districts. This guy was refusing to go to the hospital. He was afraid. He did not even want to be tested. He just suspected that he had COVID-19 until his daughter, knowing that, feeling that her father was dying, reached to my son because she knows I speak in the media, I am on television, radio, I speak about the health issues. And I spoke with her, and she gave me contact of her father. I spent some time speaking with him on how he should get tested, he should know his status, and that people are recovering. It was a lengthy talk. After that, he got tested. He had COVID-19. He went into a treatment center, and we're talking frequently, talking. Then when he was discharged. Even right now, we talk quite a lot. He appreciates that time. He was supposed he would have died, and some of such people might also have died. The last point is where this should be advised, and this must also be tackled, where people, men do not talk out in general. That men must be encouraged to share their fears with somebody. They die in silence, and it becomes worse during pandemics, especially when either they suspect they are dying, or when they think they'll be leaving their loved ones. Can we go to the next slide?
Yeah, sure.
So that will be the conclusion of the presentation, which is cementing that mental health is important. People are dying because of mental health, not because of healthy conditions that they are in, and it should not be overlooked. Yeah, so I now finish my presentation at that point. Thank you very much.
Thank you so much, George, for that presentation, which gave us a lot of context into what's going on in terms of the mental health landscape, not only for healthcare workers, but also for communities in Malawi. I believe it was insightful, and it kind of reflected what's going on in the other African countries too. At this point, I don't know if anyone had any questions, concerns, or contributions, but I think my first question, just to the rest of the members, is how did the pandemic affect your mental and emotional well-being, especially in light of having to interact with communities and healthcare workers, as well as just even in a personal capacity with your family, if you got COVID as well? How did that affect your mental and emotional well-being? Anyone can feel free to chip in, and also just letting us know how you coped as well, just because in a space of sharing some of our coping mechanisms would be important for some of us to also adopt some of these for a more healthy way of dealing with not only pandemics, but also just illness in general, and when we're feeling a bit off. Yeah, go ahead, Mary. It's Mary, I can see your hand. Go ahead.
Oh, thank you. Thank you so much. I want to thank my brother George so much for what he has shared. And something has struck me, and it is what he mentioned actually resonates with my experience, because I was part of the rapid response team in COVID in our country in Kenya. And one of the things that I personally came across was we were tasked with only calling the positive, the people who are COVID positive. You are told to call them, inquire about their health status, inquire about their family. And one thing that was left out was the issue of mental health. How I wish that we had just a basic tool, maybe a 4-question tool to ask about their mental health. Because I realized one or two people that I used to talk to, actually one of them told me that my frequency of calling him or her is what kept them going, because I kept on calling even after I have done my work. So I kept on finding out how they are, have they eaten, have they, all those things. So it is very important that even when someone is isolated or when we are dealing with a pandemic, it's also important to look at other health aspects, because the health system sometimes do not strike a balance in addressing both the pandemic and non-pandemic health concerns, which leaves the person who is affected or the patient with no option. But some of them died actually, not out of COVID, but out of fear, out of other health-related issues. Thank you.
Thank you, Mary.
And Matthew, I see there's a question from Prince.
Yes. So it says, hi, George. Sorry, I can't speak where I am. There's a lot of noise. My question is, in many African cultures, mental health is still a taboo topic, especially in West Africa, where I am from, which is one of the reasons why men don't talk. How can you raise awareness and destigmatize mental health, particularly during times of crisis such as pandemics and epidemics? So I think it's directed to George, but anyone who wants to answer can answer.
Okay, for that question, Prince. I think this is why we have said talk. We need deliberate efforts, and when we talk about men, it includes even pandemic. It includes us. This faller. Yeah, it has the mindset change. It requires a lot of sensitization to be done. It will not be easy, especially that men sometimes we are compact. I think we're stronger than human. We overrate ourselves. Because of that, they say Mamuna Salira, my local language. Like a man does not cry. We should cry. Even during pandemics, when someone has just died unexpectedly. Cry. Men will not cry, and that affects them. So it's not easy. It is start to encourage, and civil society organizations, you can programs addressing men, just them to be talking. They are distressed.
Okay, thanks, George. I also see a hand from Tampos. Please go ahead.
Oh, hi. Yeah, sorry for being late, but otherwise, to answer the question on mental health during the pandemics, especially HIV into COVID times, as the organization, we are working closely with very marginalized community in the LGBTI community. So we had very traumatic cases of LGBTI people who were kicked out of their homes because remember the pressure of COVID, where like there were lockdowns and people were unable to go to work, and people like lose their jobs, and then they had to return back to their homes where they don't even have good relationships with their parents. Some were raped in those incidences, where you find that parents were not handling were not accepting their children being the LGBTI queer persons, where some of the queer people were raped by their parents. Some were kicked out of their homes, and then we had to seek to provide menstrual health, hygiene, commodities. And then we also had to liaise with the partners in Maseru to find ways of supporting their mental health, because it was indeed a trauma to the community. So we had to find the psychologists and also people who could provide care, pastoral care and support. And we also had some of the colleagues who, or the committee members who lost their parents and who were also going through phases of trauma. So there had been a lot that was happening, and we were also trying to provide like emergency support, food packages, shelter and stuff. So yeah, it's a quite interesting topic to discuss and to reflect on, because most of our organizations, like not necessarily organizations, but in our countries, mental health issues are not prioritized. So for me, for us as the organization, we find very important to prioritize mental health issues within the key populations. Thank you so much.
Well, thank you, Campus. So I think that there was another question from a colleague. George, you mentioned, I think, a very important topic of using telephones to contact people who are suffering from mental health issues. I think they'll call it telemedicine. So, but the issue in most African countries is the issue of infrastructure. So you'd see that most of the people, especially in rural areas, right, they don't have access to the internet. Some of them, they don't even have access to the phones. So because sometimes of network issues or because they just don't have the gadgets. So how can we bridge this gap? Like, how can we try to close this barrier to ensure that while mental health services are offered remotely, sometimes let's say through cell phones to the colleagues that are in towns, but the people in rural areas can't have access to these services, how can we close this barrier? What are some of the steps that can be taken by, let's say, African CSOs, the private sector, or the government to close this gap? Anyone can answer, but I think it was directed to George.
Okay, and the others can come and also acknowledge the submission by the that it did me one more we can add the presentation that mental health. Okay, I think I wrote it in the conclusion. If you talk, we can share the conclusion at any time. Not that the conclusion for the presentation. I talked about curricula. So it has reminded me that mental health should not only be to the professionals, but everyone must be an expert. Here we are talking about starting with the family members, a spouse, and everyone. Sometimes you're going to see someone, but you don't do anything. It is not only for healthcare workers. It is not just a health issue. When we talk about them, they handle you, whichever office. So I would do that. This must be in our curriculum and provide social support, and the major skill to be imparted to everyone is to listen, because that's the first thing. You must be listened to. If people cannot listen to you, if people do not have time with you, then that's where you have such problems. And now coming to your question, can you remind me the question again?
Okay, so I think the question was, so you talked about offering some mental service help to some colleagues in Malawi.
Okay, yes, infrastructure. Yes, you've given infrastructure. Like in the rural areas, sometimes there's no phone network, there's no internet. We needed to start, and we talk about the health sector, and we talk about the social determinants of health. So we can see, as we have seen in other areas like water and sanitation, road network, that they are connected to the health sector. The phone, we have only seen the phone connected to the health sector for referrals, like the call for an ambulance. But here, such infrastructure must be seen as a social. So we can the way internet network extend the coverage. We must advocate for extension of the coverage just because of mental health to our phone, internet providers. And that is in the long term. It may not happen now. For the short term, like social welfare, where there's the health department must be encouraged to even have mobile visits to some hard-to-reach areas where they can announce will come if anyone has an issue can sit down. They should even use postal addresses, encourage people to even write. I know it can take time sometimes to respond to get a letter, but we should have a hybrid of systems in place as we expand our network or internet coverage.
Thank you, George. I think also probably for CSOs also that deal or that works in the sector of mental health and that are affected by the issue of infrastructure, they could also use, for example, in countries such as Zambia, I believe Kenya, where new technology such as Starlink is now available. They could make use of these new technologies, set up centers where probably there is a Starlink provided network that can connect in all rural areas. So now instead of trying to connect using our traditional mobile carriers, you can connect through Starlink, which is not affected by network issues, thereby bridging this gap between those people that are living in towns and those people that are living in rural areas. As probably most of you know, Starlink is not affected by the issue of people that are living in towns or people that are living in rural areas. As long as you have a clear view of the sky, you can have access to the Starlink. So this probably applies to people that are living in countries where this service is now available, such as Zambia. I think Kenya, I believe Nigeria is now also available. So I think George, probably this would probably be the last question, but I will share what Mary had shared in the comments. So we have community health volunteers, promoters who are tasked with health education, mobilization, house visits, etc. Can they be equipped with basic tools which they can use during house visits for assessment and prevention? I believe this was a question, right, Amir? Hello, Mary.
Oh, Tukuzo, that was actually more of a way forward for those of us who are coming from different countries where we are able to change policies or even come up with a way forward in our counties. It's not a question. Can we come up with at least a basic tool like the one used for substance use, the cage? Those of you who are used in substance use, there's something called cage. It's only 4 questions. So these community health promoters are able to ask those 4 questions. Based on those 4 questions, they'll be able to tell by the time they're leaving that household whether there's an issue of mental health in that house. So in that case, we are able to tackle the issue of mental health at household level.
Well, this is fantastic, Mary. Thanks for sharing. I think that covers one of the questions that was asked, where can you share some of the resources or infrastructure that people can use to help relatives or friends that are suffering from mental health? I think for the interest of time, I'm seeing that we are 3 minutes past time. If there are no questions, I would close this meeting. Thank you, George, and thank you to everyone that attended.
Possibly, I think you did ask me to briefly just to say what I do. Should I?
Oh, yes, you can just briefly say it, then we can close the meeting.
Okay, thank you very much. I work for Malawi Health Equity Network. This is a network of over 90 civil society organizations, both local and international NGOs and the researchers, academicians interested in promoting quality, equitable, accessible, responsive healthcare services. We do a lot of activities implementing on reproductive health rights, maternal issues, health systems strengthening. But as a civil society network, we we are mainly in health advocacy. So as executive director of the organization, I do advocacy, like reminding duty bearers, including government, to do their legal mandate to the citizens. We do social accountability where something is not working well, including budget analysis, budget tracking in our hospitals, and as well tracking resources such as medicines and human resources. As Martin said, for this to work, we have made sure that we build a good relationship with the government, not to be on their bedside, but they should appreciate that we go there with evidence. And we have seen that whenever government is developing policies, we win, and sometimes we don't win, but we are invited. I am able to write the Minister for Health when there is an issue that requires that office or the Secretary for Health, any director, to have responses. In Malawi, to ensure that also we created what we call Malawi Health Forum. On that forum, we have senior government officers, principal secretaries, heads of parastatals, heads of NGOs, international organizations, local organizations, including development partners, and they discuss health issues. Something can be brought there, and it is discussed, digested, to ensure that there's a forum for Malawians to do advocacy directly with the bearers. So this is what I do. I work very closely with the media. Almost every day I'm interviewed by more than 5 or 10 media houses, sometimes even 20, 30 media houses, to respond to issues that have just occurred. Thank you very much.
Well, thank you very much, George. Thank you very much to everyone that attended. So you could look forward to the recording of this meeting probably on our YouTube in the coming weeks. Have a wonderful day. Thank you.
Thank you very much.
Bye.
Bye. Thanks, Taku.
Thanks, Barack.